Hello, I'm Professor Patrick McGorry. Welcome to today's webinar. Before we proceed, as Executive Director of Orygen, I would like to acknowledge the traditional custodians of the land on which we work around Australia and pay my respects to elders both past and present.
Hi and welcome to today's webinar presented by Orygen, the National Centre of Excellence in Youth Mental Health. Today's webinar topic will be on self-harm and suicide prevention in young people. My name is Anna and I'm your youth convener for today. I'm a university student currently studying psychology in my 4th year at Monash University. I'm also a member of the Youth Advisory Group at Headspace Sunshine, and my passion and interest area revolves around mental health advocacy and awareness in the wider community. Today's webinar is presented by Dr. Katrina Witt. She's a postdoctoral fellow, a research fellow from Monash University, and her key interest is around developing and evaluating novel interventions for the prevention of self-harm and suicide. So welcome.
Thank you very much. Thanks for having me.
So we just wanted to take this opportunity to acknowledge our collaborators who make this work possible. Everything's a joint effort.
Absolutely. Okay, so today we're firstly going to be touching on what the current evidence is for interventions for the prevention of self-harm and suicide in young people.
Yep.
Secondly, we're going to have a look into some of the future directions that we need to take to identify modifiable risk factors when we're developing interventions. And lastly, we're going to review some of the limitations of current evidence base to see where we can take these interventions going forward to be more effective.
Cool. Awesome. And I just wanted to touch on the target audience for today's webinar. So we've got here clinicians, researchers, and also young people and their carers. So we think it's really important that we want, I guess, to make clear that everyone should be empowered to know what options are available and out there. So, yeah.
Okay, so the most recent comprehensive review of the current status of the evidence for interventions to prevent repeat self-harm and suicide in young people is this Cochrane review, which is publicly available, so anyone can access it. It was published in 2015. And it included all randomised controlled trials, or RCTs, of interventions that were developed specifically for young people who already had a history of recent self-harm. So they had already a few episodes within the last 6 months before they enrolled in the trial.
Okay.
We identified 11 trials of interventions specifically developed for young people. This compares with the partner Cochrane review of this one, which was for adults, in which we found 66 trials. So there is a bit of difference in the evidence out there. But we were able to include data from just over 1,000 young people in those 11 trials.
Okay.
All of the trials that we were able to identify were of psychosocial interventions, so there were no trials of pharmacological or drug treatments. Mostly these trials evaluated group-based cognitive behavioural therapy, or CBT. The next most commonly evaluated intervention was dialectical behaviour therapy, or DBT, and that had 2 trials. And then the remaining trials that you can see on your screen were only evaluated in 1 trial each.
Okay.
So this is conventionally how we would present the results from a meta-analysis, and so I'll walk you through what this actually means.
Yeah, definitely. It's an interesting slide there.
So this is what is called a forest plot.
Okay.
So because the outcome we were interested in this trial was repetition of self-harm, which is a dichotomous or binary outcome. It's either the young person repeated self-harm or they didn't.
Okay.
So the effect size we were looking at was the odds ratio, and it tells you how many times less likely or more likely those in the intervention group were to experience a repeat episode of self-harm relative to those that were allocated to the treatment as usual arm.
Right, okay.
Any effect size that intersects the line running down the middle of your screen, which is 1, is the effect null effect. It shows that there's no difference in repetition in the intervention group compared with the treatment as usual group.
Okay.
Anything that's on the left-hand side of that line is effective in reducing repetition of self-harm,
Yeah.
and anything on the right-hand side of that line demonstrates that there was actually an increase in self-harm in the intervention group compared with the control group.
Okay.
Overall, the pooled effect size, which is indicated by the black diamond in the middle of your screen, demonstrates that group-based cognitive behavioural therapy, which is the therapy that was examined in these 3 trials, did not significantly reduce repetition of self-harm in the intervention group compared with the control group.
Right. Okay. Can you tell me why is it the Hazel study is on the other side of the line, so it's on the right-hand side?
Yeah, absolutely. So although these trials all examined group-based CBT, so a very common intervention with common components, the way in which it was evaluated and what happened in those trials was slightly different. So the Hazel trial, for example, there was an adverse incident in it. It's the only Australian-based trial of this therapy, but there was an adverse incident, unfortunately, where a participant in the group-based therapy actually shared via a web blog confidential information about other participants in the therapy session, which might have had some effect on this.
Yeah.
The Wood trial too, which is the last trial on the screen, it's important to acknowledge that for that trial, the definition of repeat self-harm differed, and that might be why that one's demonstrating a significant effect when the other 2 don't.
Yeah.
So in the Wood trial, any repetition of self-harm was actually taken as there being 2 or more episodes within an individual.
Yeah.
Whereas for the other 2 trials, it was 1 or more episodes.
Okay.
So it just demonstrates to you how these slight differences between these trials in terms of how the therapy was delivered, but also in terms of the definition of the outcome measure, can have quite big differences on what we might conclude as to whether an intervention is successful or not. And it highlights really the value of having a meta-analysis that kind of gives an overview of this.
Definitely, I agree.
So in this trial, we're looking at 2 different sets of therapies. The top set of therapy is dialectical behaviour therapy, or DBT, and that was evaluated in 2 separate trials.
Yep.
And then at the bottom, we have a single trial of mentalisation-based therapy. Both of these are psychological therapies, and they generally tend to be reserved for young people demonstrating borderline personality disorder symptomatology. So they're more prolonged treatments. So group-based therapy, cognitive behavioural therapy, for example, is delivered over 6 to 12 weeks, whereas these kinds of therapies tend to be delivered over 12 months.
More long-term.
Absolutely. Yeah, because of the personality disorder symptomatology that's going on there, it takes a lot longer to kind of address and treat that.
Yeah, definitely.
So what we find in these 2 types of interventions is, again, we don't find for DBT, we do not find a significant reduction in the proportion of adolescents in the trial who have a repeat episode of self-harm, but we do actually find evidence of a significant treatment reduction in the frequency of events per individual. So they might not be stopping self-harm completely, but they are experiencing a reduction in the frequency with which they engage in that behaviour, which is actually quite a valuable outcome for personality disordered young people.
Absolutely.
And the mentalisation trial, although it's a single trial, it's a fairly significant treatment reduction that we find. And in that trial, we find a reduction both in the number of young people having at least 1 repeat episode, as well as the frequency as well. So there's some good emerging evidence for these 2 intervention types.
Cool. Can you tell me more about the new family therapy trial?
Absolutely. Yeah. So there's just recently, within the last couple of weeks, been a new trial recently published of family therapy, and that didn't show a reduction in the proportion of young people repeating self-harm. I don't have the results included in this. I need to redo the analysis. But we think that, unfortunately, it hasn't demonstrated as strong an effect as had been hoped for. Okay, so basically taking all of that evidence together, the fact that we only had 11 trials and just over 1,000 young people in those trials, we need to start reflecting on where are we, where is the status of the evidence, and what do we need to find out in order to be able to more successfully treat self-harm and suicide in young people. So this particular review on your screen was a systematic review of all observational studies that reported risk factors or protective factors for the repetition of self-harm in young people who were already in contact with clinical services.
Okay.
We found 17 studies, and we included almost 11,000 young people in the analyses. And we measured the we measured the magnitude of the association between the risk factor or the protective factor and repetition of self-harm using odds ratios, as we saw before.
Yeah.
But in a novel contribution in this particular paper, we also looked at the likely effect of eliminating the risk factor from the population of young people who engage in self-harm, and looking at what might be the most promising risk factors to target as a consequence of those analyses.
Okay, cool.
So in this table, we're presenting basically the factors associated with repetition of self-harm in young people.
Okay.
You can see the factors, the historical factors that are listed on the left-handmost column. Then we have the pooled odds ratio, which is the magnitude of the association.
Okay, yeah.
But then arguably it's the next column that's most interesting, which is called the population attributable risk fraction, or PAR for short. And that takes a percentage out of 100. And it basically indicates if we were able to eliminate the risk factor, exposure to the risk factor, it would reduce the repetition or the risk of repetition within young people generally by the percentage.
Yes, definitely. Okay, that makes sense.
So taking, for example, sexual abuse, which is the last risk factor that we looked at in this domain, you could argue that this isn't amenable to change, because you could argue it's a historical factor. It's happened, it's a fact in the past. But actually, you can change how that is processed by a young person through therapy. So you can change the effect that having experienced that has on a young person's ongoing mental health. So it kind of sits a little bit in the middle, actually.
Yeah, definitely.
So you can see, if you look at the pooled population attributable risk column, that if we were able to eliminate sexual abuse and eliminate the ongoing psychological effects that that has on a young person, we could potentially reduce the repetition of self-harm within the population of young people at risk of repeated self-harm by almost 13%, which is quite significant.
Yeah, definitely. It's really interesting. Okay.
On this next slide, we're looking at exactly the same things, so risk factors associated with repetition of self-harm. But on this slide, we're looking at clinical and psychiatric factors. So these are the ones that are more traditionally thought to be amenable to intervention, more so than, say, the historical factors.
Yes.
So we find, for example, that being diagnosed with any mood disorder, if we were able to eliminate exposure to that, mood disorders, if we were able to achieve earlier treatment, we could potentially reduce the risk of repetition of self-harm by around 42%. If we could eliminate exposure to any personality disorder and the ongoing effects that that could have for a young person, we could reduce repetition of self-harm by about 16%. If we could eliminate borderline personality disorder, we could reduce risk of repetition of self-harm by around 42% as well. And hopelessness scores and suicidal ideation scores, the two down the bottom, they were also found to be significantly associated with risk of repetition. But we couldn't calculate the degree by which eliminating exposure to those would reduce risk of self-harm repetition, because they're measured on a continuous scale. They're not a dichotomous yes, no, outcome.
Yes, absolutely. Well, those figures are really great to see, because it really does show that there can be improvement.
Yeah, and absolutely. The interesting thing really is, if you look at the two personality disorder variables, they contribute quite a lot of risk. And they are actually the focus of treatment for DBT, dialectical behaviour therapy, and mentalisation therapy, which we saw showed some promise. So that's kind of tallying with what we're seeing in terms of the interventions. So it would suggest that if we could have more content around mood disorders in treatment, or self-harm and mood disorders, if we had conjoined focus on those in therapy, we might be able to achieve greater reductions. And if we were also to include aspects around trauma-focused psychotherapy for children that had been exposed to sexual abuse or physical abuse as well, we might be able to achieve further reductions.
Yeah.
But currently, the specific focus on mood symptomatology sometimes is absent from some of the interventions we've looked at so far.
Right.
And trauma-based psychotherapy also tends to be absent from the therapies that have been evaluated so far. So it points to some future directions.
Yeah, absolutely. Okay, so with all that you've summarised so far, where does that leave us now really going forward? What do the limitations look like?
Yeah, absolutely. So in this next paper that I've got the citation, and again, all of these are freely accessible, so any member of the general public can access these papers.
Yeah.
We had a look at 18 trials of cognitive behavioural therapy for the prevention of repeat self-harm. I must highlight that these interventions are in adults this time.
Okay.
The analysis specifically to what impact this has on young people is still ongoing, and we don't expect to have the results for that for another couple of months. So just
good to highlight.
Good to highlight, absolutely. So in this particular paper, we were particularly interested in looking at variability in treatment as usual condition.
Okay.
Because in the past, in these trials, treatment as usual has been considered a fairly homogeneous or very similar construct between trials, when in fact it's actually not. It's an evolving treatment.
Yeah.
So we wanted to look at whether evolution or differences in the composition of the treatment as usual arm in these trials had an effect on whether we considered an intervention to be effective or not.
Okay.
So we found, and I'll show in the next slide, we did find that there was a significant difference.
I'll just go to the next slide.
So what we did is we took these 18 trials and we grouped them into 3 separate subgroups or 3 separate groups. And membership to those groups depended on what was offered in the treatment as usual arm.
Okay.
So in the first group, which is by far the most amount of trials, the treatment as usual group comprised multidisciplinary treatment as usual, which we basically defined as needed for the patient, the individual patient, referral to psychosocial therapy.
Okay.
Treatment by pharmacological therapy or drug therapy, or a combination of those two, depending on treatment needs.
Right.
The second group, which involved 2 trials, was where the treatment as usual, they received a referral to the general practitioner only.
Okay.
And the last group, which included 3 trials, was where the treatment as usual, what the participants in that arm actually received wasn't very well described. We couldn't make a call as to what they actually received.
Yeah. Okay.
So you can see where you compare the treatment effect where treatment as usual is unclear or not described versus where it comprises multidisciplinary treatment as usual. There's a 3-fold difference in the treatment effect between those 2 groups.
Okay. And why do you think that is?
So we think that one of the major contributors to this particular result is that you can see that the pooled effect size where treatment as usual is multidisciplinary is only just significant. It's only just left of that central line.
Yeah.
And we think that that's probably because over time multidisciplinary treatment as usual has come to look a lot like cognitive behavioural therapy. So it's come to look a lot like what is actually the intervention treatment.
Yeah.
So it probably underscores why you're finding that there's sort of not much difference when you've got multidisciplinary treatment as usual.
Yeah.
Whereas when treatment as usual isn't very well described, these are 2 older trials and 1 trial from China, and it's probably likely that the participants in this arm didn't receive much in the way of intervention, or they received very basic sort of intervention and not an intervention that looked similar to cognitive behavioural therapy.
Right. Okay.
Other things to consider when you're looking at this evidence, and to think about in particular, to think for researchers where we might need to take this field forward so we can answer some of those questions around what we should be doing to help young people who self-harm, is having a look at the fact that to date there's been very limited involvement of youth in co-designing these interventions.
Right. Okay. So what do you mean particularly with co-designing?
Okay. So this is involving young people in the content of the therapy and what it might look like. So what examples might be given when you're giving cognitive behavioural therapy, what the exercises might look like, and also what concerns might be addressed in the content of the therapy. So a lot of these interventions have been developed for adults, and they've been minimally adapted for young people.
Right.
So they're not very developmentally sensitive.
Yes.
They also don't really address risk factors or protective factors that might be important to a young person in that developmental stage of their life. So things around, for example, sexual identity are largely absent, as well as things to do with group membership, bullying, any of those things that might be more developmentally appropriate at that particular life stage.
Yeah. Okay.
So genuine co-design, therefore, it remains quite rare, and that's particularly so for culturally or linguistically diverse groups as well.
Okay.
But there's a notable exception, which is the paper that I've put on the slide, which is by Christabel Owens. This is a really honest paper of her experiences in co-design and participatory workshops with young people.
Yeah.
Because she developed a text messaging based intervention which had gone through a lot of iterations with academics and with researchers and clinicians who work with young people to the stage that they thought they had a deliverable intervention.
Yeah.
They then took it to a co-design or participatory workshop with young people.
Okay.
And the young people just thought it was, it was not, it didn't click with them. It didn't click with their life experience. It didn't click with the way that they would access services or the way that they'd even express their own problems.
Okay.
So in this paper, she honestly describes this process and how it actually took her 2 years from what she had thought had been an implementable intervention to something that actually was palatable and would be used by the young people themselves.
Yeah.
So it just shows you the amount of time it can take to get to a product that young people actually like, that actually resonates with young people. It could be up to 2 years.
Absolutely. And I guess in this case it would have had to have gone further after she realised, well, hey, this intervention isn't what they want.
Yeah.
And it's not something that they're going to use. So
Absolutely.
So co-design is really important in this.
Absolutely.
Yeah.
Absolutely. And can be a quite involved process, taking multiple iterations and taking time.
For sure. Yeah. Okay.
So other limitations and future directions, as we touched on earlier, differences in the treatment as usual condition makes a significant contribution to whether we conclude an intervention is effective or not.
Yeah.
But we don't really analyse that to this extent, to that extent currently.
Right.
So it does suggest that for researchers who are working in this field, we need greater clarity in what actually is received by the participants in the treatment as usual condition and to what extent the treatment as usual condition starts to look a lot like the intervention that's being trialled.
Yeah.
We therefore suggest for researchers working in this field, greater use of head-to-head or decomposition trials might be required, which can reveal the component or components of these interventions that are associated with the treatment effect. Because at the moment, a lot of the interventions trialled in this group are multi-component.
Okay.
They consist of, cognitive restructuring, behavioural activation, third wave techniques like mindfulness, and you can have assertive outreach, all sorts of compliance enhancement, all sorts of components. It's a little like throwing a handful of darts at a dartboard and seeing what sticks.
Yeah.
We need to get beyond that. We need to be able to make more informed decisions as to what are the components we need.
Yeah.
The other thing, if we can achieve that as researchers, the benefit of that to young people and their carers is that we can potentially reduce the length of time of these interventions. So I touched on earlier that DBT, dialectical behaviour therapy, is about 12 months for treatment. It can be shorter for young people, but between 9 to 12 months.
Yeah.
That has significant implications for a young person's enthusiasm in participating for that long.
Yeah.
Also, that's going to have knock-on consequences for their adherence and their likelihood of coming to successive treatments, especially when the number of sessions is often 2 or 3 times a week, which is quite a significant burden.
Definitely, yeah.
So if we can, as researchers, can get a better idea of what are the components that are associated with the effects that we're seeing, we can perhaps streamline these interventions and reduce their length and complexity, which will only be of benefit to young people.
I agree.
The second thing we really need to understand is the pathway to self-harm. So a lot of these trials measure a variety of secondary outcomes and a primary outcome, which is usually self-harm.
Okay.
The secondary outcomes in these trials include a whole host of different things. But commonly you've got suicidal ideation scores, you might have depression scores, hopelessness scores, those kinds of things.
Yeah.
But we don't really know what the relationship of those secondary outcomes are to reducing the primary outcome, the self-harm.
Mm-hmm.
So we really need evidence-informed, directed excellent graphs to identify what the possible sources of confounding are and to clarify the relationship between these sorts of variables so that we know that, for example, is it impacting change on hopelessness, and does that then have effects for suicidal ideation, which has effects for self-harm, or what
definitely. And a lot of the time it is a really complex relationship, and if you're going to try to intervene and treat that, it's really important to have a good understanding of what that relationship looks like for each individual.
Yeah, absolutely. And then the last thing we really need to consider too is that, as I've touched on already, a lot of these interventions were developed for adults, and they're really only minimally adapted for young people. And that adaptation really is only around sometimes the length of the treatment, but more often than not it's around the examples that are given and the homework exercises that are given and what the content of those things are, rather than the treatment as a whole. Looking at the treatment as a whole, looking at, is it palatable to young people? Does it resonate with their experiences? Does it address the things that are important to them at that particular life stage? So again, we need to understand the needs of young people who are engaging in self-harm, the reasons they're engaging in self-harm, and why. What is the purpose of self-harm to them? So that we can actually more cohesively design interventions, and interventions that have been co-designed specifically to meet their needs in a manner that resonates most with them.
Yeah, absolutely. Awesome. Well, thank you so much for joining us today. I really enjoyed your talk. It was very insightful. And thank you all for joining in and tuning in with us. Bye for now.
Thank you.